All right, can you hear me? Let's get started. Welcome, everyone. My name's Susan Barber Lindquist, and I work here at Mayo Clinic Health System in Eau Claire in Public Affairs. And I wanted to wish you all a happy Valentine's Day Eve. And I know there's no such holiday as Valentine's Day Eve, so don't worry about that, men. But it's a great day to learn more about our own heart health and that of our loved ones. So tonight we're going to hear from the medical experts. They're sitting up here.
Well, it's the number one killer among...
That's not the medical expert. I'm already going to say Jamie, and I just got to say, Jamie, who is our AV specialist, he's responsible for these hearts here. So I'm going to hope that I can get out of this endless loop he's put these couple slides on.
Yep, you're in control there, Susan.
Oh, excellent. That's what I love to hear. All right. And we're going to hear from the medical experts from Mayo Clinic Health System in Eau Claire and two women who are heart survivors. And we can't thank them enough for being here. So let me introduce them all. We have on the far side here, Dr. Wickman, can you give him a wave? Cardiovascular surgeon, Dr. Bob Wickman. Next to him, we have Sheila Dutton of Bloomer. In the middle, we have nurse practitioner Sue Pope. And then next to her, we have Sharon Durbin of Eau Claire and cardiologist Dr. Regis Fernandez. So before we get started with the women's stories, I want you to know that our moderators, Dr. Wickman, Dr. Fernandez, Sue Pope, they're part of the Cardiac Center here at Mayo Clinic Health System in Eau Claire, which earned a top national ranking by U.S. News & World Report. That's our slide we have up here. The magazine, if you're familiar with that, they rank all sorts of medical programs across the country, and they earned a top ranking in the nation. So we're very proud of that, and I just wanted to let you know that you're in really good hands tonight. So, I want to raise your hand, let me know, have anybody seen these billboards around town? They're fairly new, maybe last 2 weeks. Anybody seen them? There's a hand. There's a couple hands, very good. It's part of a new campaign Mayo Clinic Health System started to encourage women to get your heart checked today. So people can go online to mayoclinichealthsystem.org, get checked. That's the address you see there. And plug in their own information and about their blood pressure and cholesterol and things like that, and get a good idea about their personal risk of heart disease. And that's because the risk for women is real. And that's what we're going to hear tonight. Things that will show you that these facts are real. Heart disease is the #1 killer of women aged 20 and over, which that surprised me. Every year, over 500,000 women in the United States will die of heart disease. This year alone, 1 in 3 women will die from heart disease, which is 1 woman every minute. More women die of heart disease than the next 5 causes of death combined, including all forms of cancer. 90% of women have 1 or more risk factors, such as diabetes or high cholesterol. The good news, and Dr. Fernandez, I know will talk about this, is that 80% of cardiac problems may be prevented. That means us making choices, those choices you made tonight for the fruits and vegetables. I see we're all more fruit lovers than vegetable lovers. Those are what's going to help protect us, and quitting smoking. So, before we get started for Sharon, we're going to show you this WQOW news clip that I bumped across here earlier, and then we'll hear from Sharon herself. And then we'll let the medical experts interpret a bit, and we'll open it up to questions, so you don't have to think and hold on to your question. We want this to be a conversation, and that's what's really nice about tonight, is having these resources here to just ask, and you here with your questions. So let's see here. If I can make this work.
Well, it's the #1 killer among women, yet there's a stigma attached. Heart disease is typically thought of as a man's disease. On the eve of February, which is Women's Heart Health Month, Kristen Schill shares one woman's story of the heart.
7 years ago, chest pain woke Sharon Durbin up in the middle of the night.
I thought this must be what a heart attack feels like.
As a nurse, she ignored her instincts.
I knew my husband had to get up early for work, and I wanted him to get a good night's rest. I didn't want to bother him. I knew the doctor needed his rest. I didn't want to bother him.
She had a glass of water and went back to bed.
I thought I could just wait till the next day, and I guess I was one of the lucky ones. But, you know, I probably should have called 911.
Women also tend to be more in the caregiver role in their families. They think about everybody else's needs. They don't necessarily think about their own.
Now, to lessen her pain, Sharon goes through EECP, or Enhanced External Counterpulsation,
I have chronic angina, chest pain.
which requires her to be strapped to this machine for an hour a day for 50 days straight.
The compressions are synced with my heartbeat. So if my heartbeat's irregular, then the compressions and the tightenings will be irregular too. So it can be uncomfortable at times.
The treatments lessen her pain for 6 to 9 months, which is why Sharon has had 4 of the 50-day treatments so far.
I ate healthy. I was a healthy weight. I was a runner. I've run marathons. You know, I was never a smoker. So I don't know what I could have done different.
Reporting for Eau Claire's own News 18, I'm Kristen Schill.
All right, Sharon, we're going to let you tell your story in your words.
I would like to begin by sharing one of my favorite concepts. It's a quote, and it's the basis of my life's journey. Your journey has molded you for your greater good, and it was exactly what it needed to be. Don't think that you've lost time. It took each and every situation you have encountered to bring you to the now, right here with me, and now is right on time. My health struggle has led me to examine this belief in full. I have come to realize that I have had the most priceless opportunity to meet some extraordinary human beings, from patients to nurses to physicians. This journey is not about what I have lost. It's all about what I have gained. My name is Sharon, and my heart story is simple and an all too familiar tale of feeling indestructible. My story begins in July of 2007 when I was awakened by a heaviness in my chest. It was very typical. It went to my back, it went down my left arm. I could feel the heaviness, and I thought to myself, this must be what it feels like to have a heart attack. I was restless, I was fearful, yet I moved from the bedroom, I went into the family room, I tried sitting up straighter, I tried drinking water, I even took some Tylenol, but I thought I knew my husband needed his rest, so I needed to just sit alone and wait. The pain persisted. I sat alone and I told myself, I can make it through this. After all, I am a woman. I am also a nurse, and you'd think that would make me smarter. Contrary, I know how hard doctors work. I know they have terrible schedules. I know how demanding patients can be, and I didn't want to be one of those patients. I knew I could make it through. I didn't want to bother anyone. I kept telling myself I was too young to have a heart attack. I was 56 years old. I was too healthy. I was a runner, and I just completed Grandma's marathon. My mind wandered. I thought about my father. He had his first coronary bypass surgery when he was 41, and he had a second bypass surgery when he was 51. But you know, I am a woman, I'm strong, I'm a super mom, I'll be fine. And so that being the case, the next morning I got up, I felt terrible, I went to work, and I smiled, and nobody knew the difference. I got home in the evening, and I thought, I'll take a walk, I always feel better, and I walked, I was okay. Then I started running, and I got that chest pain back. Both of my arms just felt numb. I went home, and I went to bed. And I thought at that point I should probably call my internal medicine doctor. The rest is history. My internal medicine doctor told me that she would order a CT angiogram just as a precaution. She didn't seem very concerned. She told me to start a regime of Prilosec before supper and Pepsid AC at night, and I thought, perfect course of action. But as soon as I returned home from the angiogram, I received a phone call and was told to return to the emergency department to be admitted. It was surreal. After that, I just thought this was happening to somebody else, not me. After all, I was that super woman. My CT angiogram was read to be of high risk because of multi-vessel obstructive coronary artery disease, and I was having episodes of unstable angina. I had a cardiac catheterization and 2 Cypher stents in my LAD, left anterior descending coronary artery. I was told that I have small vessels that are blocked, and they're too small to stent. It was known as microvascular disease, and this would be treated with medications and something that was known as EECP. I remember when I first talked to the cardiologist, I remember his exact words. He said, we cardiologists, we love to fix things. You cannot be fixed. Those words had a huge impact on me. I knew I had to work hard. I knew I had to eat right. I knew I had to exercise. I've continued to have angina since that time. Some days are good, some days are bad, some days are scary, but it's my new life. It takes real determination and strength to circle the dessert bar at Fanny Hill. That's only one of the places I like to treat myself. And I have been able to avoid that rich, creamy, fat-laden fudge at the Shields Coffee Bar, but I look at it, and when they ask me, can I help you? I just say, no, I'm just looking. But yes, I was secretly hoping someone would buy me some Butterfinger fudge for my birthday, but never happened. Maybe next year. So I continue to walk every day, either on the treadmill or on the bike trail. I go to sleep each night at the right time. I take a boatload of medications, and I try to live life devoid of inflammatory effects of strong emotions. I learned about a treatment called Enhanced External Counterpulsation, or EECP, and it has been my salvation. Since 2007, I've had 4 series of 50 sessions of EECP. It has given me my life back. The sessions are daily and consist of a series of 35 to 50 hour-long meetings. I realize this is my hope. I've learned that everyone needs hope, no matter how small it may appear. EECP is approved by the Food and Drug Administration and is a non-surgical therapy for angina, promoting the development of collateral coronary arteries. It's used in prominent clinics like Mayo Clinic, Johns Hopkins, and Cleveland Clinic. I know the process well. After I stretch into a pair of navy blue leggings, they put electrodes on my chest, and they wrap pneumatic compression around my thighs and my buttocks and my calves. The cuffs are attached to air hoses that connect to valves that inflate and deflate the cuffs based upon my heart rate. Studies have shown the process stimulates the formation of collateral blood vessels in the heart by stimulating the release of nitric oxide. Collateral arteries are small blood vessels that open and create a detour for blood to flow around blockages in major arteries. EECP has been the route for me to go. It requires no surgery. It is less risky. It is less pain. It is performed on an outpatient basis. It's lower cost, and I know it will work. I have less angina and take fewer nitro in the end. The success rates that I researched range from 80 to 90%. I could go on about EECP. I could go on about heart disease in women. I know it can get overwhelming and mind-numbing when people start talking about their medical history. If you're more interested in EECP, I have a blog, This Old Heart blog, that talks about EECP and gives lots of tips and insights. Incidentally, you will also find a follow-up to the EECP post called Socks Are the Voice of the Heart. A funny thing happened along my heart journey and all my ECP visits. One of my tips for ECP on This Old Heart blog was to wear fun and colorful socks, because that's what you see when you're on the table. It adds some novelty to your treatment, both for you and your nurse. After that post, I received several pair of socks, and I felt the center's compassion and caring every time I looked at my feet. Now I feel the socks are the perfect accessory for EECP and for everyday life. So this has been my heart journey. Sarah Teasdale said, I make the most of all that comes and the least of all that goes. So coronary artery disease, in a way, added to my life and gave me the most beautiful gift of all. I now have the full awareness of my last 60-some years of life in the best possible way, with love from people that I've met along the way. They have lived, laughed, cried, loved, and smiled with me. I continually bless the present by being mindful of the now. Please remember to take care of your heart. Thank you.
I think Sue, we're going to start with you then, just to maybe reflect off what Sharon said, and then we have some slides for you about risk factors and symptoms.
First of all, that's the first time I've heard Sharon's whole story. I knew a little of what was going on with her, but what a wonderful story, and thank you for sharing that with us. Sharon talked about the risk factors that she did take care of, and she, did the running and did the exercise and really took care of the things she could take care of. But unfortunately, she had one risk factor that is unchangeable, and that's family history, and that is an important one. And we can't change that. But I want to point out, and I'm sure you realize this, your dad had a problem when he was 40, and you were 56. So what she did made a difference. That's really important to point out, and what she's doing now makes a difference. So the risk factors that we all, I think, are pretty aware of, but I want to go over them a little bit. Diabetes, people that have mainly type 2 diabetes, but type 1 and type 2 are at a higher risk. And we actually consider people with diabetes to be at a similar risk to people that already have coronary disease. So we're really very aggressive with those individuals. High cholesterol, certainly, and I know that over the last few years you've probably heard ups and downs of treatment of cholesterol and some of the different medications we have, but we have very strong studies that support the importance of treating cholesterol. So that's something that's, especially if you have a positive family history, that you want to be sure you know what your numbers are and talk to your healthcare professional about treating them. Smoking, obviously, is a risk factor for heart as well as many other things. Not an easy thing to quit, if you're a smoker, but absolutely essential. Lack of exercise, obesity, high blood pressure, those are all the risk factors that we look at. And what we really need to do, and what the new guidelines that came out last year say, is we need to really look at those risk factors and assess your overall risk and treat appropriately. So if you're at high risk because you have all of those risk factors or some of them, then we need to treat you appropriately before you have a problem or after you have a problem in secondary prevention. So those are really important. And if any of you have questions when we get done about those risk factors, we certainly can answer those for you. The symptoms of a heart attack are extremely variable, and particularly variable in women. Sharon had pretty typical symptoms, but even that, as you heard from her, we're in our mid-50s as women, or 40s or younger. Mm-hmm. We tend to say, oh, that's heartburn, or that's something else, and it can be heartburn, it can be something else, but it's something that you don't want to mess around with when you're having the symptoms, and you certainly want to get care as soon as you can. But it's very typical. Sharon's not alone in women that women and men, but particularly women that tend to minimize the symptoms and try and say, oh, this isn't my heart. So let us help you make that decision as to whether it's your heart or not and get in for help. There's a real important time frame if you're having a heart attack that we need to get you in as soon as we can, and Dr. Fernandez will talk about that in terms of stenting and getting you in quickly. So symptoms, the typical, mid-sternal chest pain down the left arm, that certainly can happen, but it can be very variable. Some people present with just shortness of breath. They don't have any chest pain at all, particularly diabetics. Some people are just nauseated or sweating or lightheaded. Sometimes it's back pain instead of chest pain. So again, and a lot of times it's epigastric pain, so lower down where you think it is heartburn. So it's hard to sort out sometimes, and let us help you sort that out. Okay.
All right. Dr. Fernandez, I have this slide that is the animated slide about stenting. Do you want to go into that, or anything else you want to say before I push on that slide? All right. Do you want to, I don't know if you can see it. Do you want to stand up so you can see the, it's because it's going to, so maybe you can kind of narrate for us when we see what's happening on the screen.
So I think it's remarkable that Sharon's able to share that experience with us, because what she's teaching us and teaching you is what we try to preach every day when we talk to patients and also when we talk to the community. So two important things that strike me here in her history. The first thing was that she had symptoms and didn't look for help. And as Sue said, this is very important. So the first message here is, if you have any symptoms that you think it could be related to heart disease, take it seriously. And we try to bring the message to women too, because women for years have thought not to have as much heart disease as men, because men over the media and over our culture has been the typical person that will have a heart attack. It turns out from the statistics that women have as much heart attack as men do. So for both genders, any kind of symptoms related to a heart attack should be taken into consideration right away. And the first thing to do is to call 911 and not to drive to the hospital. So that would be the first teaching point here. Driving to the hospital is very dangerous. Something could happen, and it actually takes longer. If you call 911, you get to the hospital much quicker. So if you think you have any symptoms of heart attack, please take action. Don't worry about the doctors and not bothering the doctors because we have a call schedule and we're here for you, and that's our job, and we're glad to take care of you. The second important thing here is the timing. If a person is really having a heart attack, there's not much time that we can negotiate as far as helping you out. So the sooner you get here, the sooner we can fix that vessel, the better the prognosis for your lifetime. So time is the essence here, and it's very important to think about that when you're having symptoms. One thing to point out here too, the difference between men and women is that women have symptoms that are slightly different than men. There was a study that was done several years ago that showed that most women, when they had a heart attack, the presenting symptom was not chest pain, and was shortness of breath. So women, sometimes they have slightly different symptoms. They don't have the typical, they can have the chest pain, but sometimes they have shortness of breath, dyspnea, indigestion, or some symptoms that are not really typical. And that's not to say that you should call 911 whenever you have any of the symptoms, but when the time comes, if you feel something that is sudden, that is persisting for longer than 20 minutes, it's in the chest, around the chest area, it doesn't feel right, could make you sweaty, could make you uncomfortable, unsettled. If you have risk factors, please think about heart disease as a symptom.
Oh, so we just have this slide that shows angioplasty and stenting. Can you tell us a little bit what's going on as the animation goes by?
Sure. So if a person is having a heart attack, one of the ways that we can save the heart muscle from damaging is by opening a blocked artery. So the animation that you can see there is showing the plaque, which is cholesterol that builds up in the arteries, like what happened here to Sharon. And then in red, you see the vessel, and inside you see a balloon that is being deployed in there, opening up the vessel, and then later a stent would be deployed in there, which is a little metal coil that will keep the vessel open and keep it patent or keeping the blood flowing through it. This is something that is done without surgery. It's done, I think most of you are familiar with that, but it's done with catheters that are inserted with an IV in one of the veins in the body, either arms or legs, and we can reach the heart with these catheters and fix things. But that's the way that we use to fix blockages once they have developed and there's no way to regress them. Medications and lifestyle changes are the first thing to do to prevent this from happening, but at times that's what we have to deal with, and that's how we fix them.
And then Sharon also talked about ECP, which I have a picture of. Maybe you can tell us a little bit more about what that was. I know some people here were particularly interested in that.
That's the second important teaching point from Sharon's story here. What she's telling us is in accordance with the literature. ECP is a technology, a non-invasive technology that helps to decrease angina or chest pain, which are symptoms that patients have. The indications for ECP are coronary artery disease, like you saw in the animation, that is not amenable to angioplasty. So sometimes we cannot do the stent, the balloon and stent that you saw there, and we cannot do heart surgery. So there are times that we cannot fix things with devices. And we try medications first, but if medications fail, then we have to use other things. And ECP is a wonderful alternative to that. Sharon has explained how that's done. The literature has shown that about 70% of patients with severe angina or severe chest pain can go down to only mild with ECP. That was a study that was done in 300 patients recently. And in about 50% of these patients, they were able to get rid of some medications like nitroglycerin. And only 20% needed to do the treatment again. And the benefit persisted for greater than 2 years after the treatment with just one session. So it's a very, very effective therapy. And I think I'm glad that worked for you. And that's available here in our in our cardiac center. We offered ECP for patients that have the indication.
All right. So we're going to invite a couple questions if you have them. Jeannie, did you get a microphone? All right. So do I got Jeannie who can come around, and if you wouldn't mind speaking into the microphone, raise your hand and she'll come to you if there's any questions. We'll take a couple now. We don't want to make Dr. Wickham and Sheila wait too long, but we'll take some now if anybody's got any particular questions regarding what Sharon was talking about. I thought a really great message was I heard Sharon talking about waiting 2 days before she came in. I heard Dr. Fernandez say about 20 minutes. Anybody have anything they want to ask these folks? We can come back at the end as well. All right, we got a question there. I'm going to have you hang on 1 minute, sir. We'll just see if we can get you to talk in the microphone so everyone can hear. Put it right close to your mouth.
This afternoon, I put in the zip code for 54701 on the appropriate page, and no EEC facilities were listed for Eau Claire. They were listed for Gunderson Mayo. They were listed for Mayo Rochester, but none is listed for Eau Claire. This is the site that is put up by the providers of the equipment that you use at EEC. So I'm glad to know that it's available, Dr. Fernandez, and you want to get on the tail of those people.
Yeah, we'll check into that. Thanks for the tip. Anybody else?
That's the best part, by the way. The questions from you that's when we learn the most. So please go ahead and ask questions. Don't be afraid.
One of the slides addressed low estrogen levels. Is there a test, or what type of tests do they run to determine that?
We don't really have to test for that. What the slide is showing there is as women go into menopause, their estrogen levels decreases dramatically. That's what happens. And estrogen is a natural protective of coronary artery disease. Estrogen helps to keep the vessels open and clean. It's an anti-atherosclerotic hormone, actually. When women go into menopause, they lose that. And so women start to develop coronary disease usually 10 years later than men. CAD, or coronary disease in men, starts to increase after 55, the step-up curve, and in women that starts at 65, so a little bit later. We don't test for that. We don't replace estrogen because the estrogen that we have to replace is not a natural estrogen. Well, it comes from the horse, so that's the one you get from the pill. And that estrogen has been shown actually to increase the risk of heart attack. So we don't replace it. We don't check it. It's just something that it's just a fact.
I just want to add, too, that we know that when you lose that estrogen, when you go through menopause, your cholesterol levels go up, the bad cholesterol, the LDL, and the HDL goes down. So that we believe that's part of the mechanism for why the incidence increases at that point.
Another question?
Sharon? Sharon?
There's
Thank
Sharon
you.
for you up there.
Thank you so much for, because I'm contemplating this and you really helped me a lot.
Oh,
But
yes, you're welcome.
Could I ask were your cholesterol levels?
I had normal cholesterol levels, but they tested for lipoprotein A, and I had highly elevated lipoprotein A, and they said it's a genetic risk factor that, is that correct? Yep.
Yeah.
That's
But-
causing most of my problems.
And by any chance, are you diabetic?
No, I'm
Okay.
not.
Thank you.
Mhm.
Thank you
Mhm.
so much.
Yep.
I got one way down here, Jeannie. We're going to make Jeannie work today. Way down in front.
As you went over the risk factors, you bypassed, or I was not paying attention, to the mental stress and depression. Could you please elaborate on that, and where does that play into, the factors, and what level is that in the
That's
situation?
a very good question, and I'm
Thank
sorry
you.
that I skipped that. I think part of the reason is we don't know as much about that. We don't know as much about how stress affects. It can affect lipid levels, it can affect high blood pressure, it can directly affect coronary disease, but I don't know if Dr. Fernandez would agree with that. It's just not something that we know as much about. Plus, it's not an easy thing to treat, obviously, in terms of reducing stress and reducing anxiety. So I think it is a factor, but how we deal with that is a little bit problematic. Each individual, how each individual deals with that? Each individual or as a whole?
The other problem is it's extremely hard to measure. You can measure your blood pressure. You can measure your cholesterol. You can measure your hemoglobin A1C to determine how your diabetes is being managed. How do you we don't have very good ways of managing somebody's stress level. And, how you manage the stress of being in the operating room is, I handle that fine. I certainly don't handle the stress of standing in line at the grocery store. So, but in all seriousness, how do you manage, stress? It's I think the difficulty we have is that we don't have a good way of making the subjective problem objective, and that's an issue.
And also, patients with depression, patients with coronary disease that have depression have a worse prognosis for some reason. It's not very well understood. Cardiologists are usually not very keen into search into that in patients, but it's something that is it's well known.
What about low blood pressure versus high blood pressure?
Okay, so low blood pressure is not detrimental. There have been some studies that have been concerned with the diastolic blood pressure, which is when you take your blood pressure, you have the higher and the lower number. So some studies in animals have shown that if your diastolic blood pressure is less than 50, the perfusion of the blood flow to the arteries of the heart decreases. But that has never translated into human studies. But it's especially in elderly patients that have severe blockages, we try to keep their diastolic pressure over 50, so we don't decrease coronary blood flow too much. That's the only thing related to low blood pressure. The systolic pressure, the top number, it's not so important. That will affect mostly how you feel and how your body feels. So we try to keep it at a normal level. But low systolic blood pressure can make you pass out, can make you dizzy, lightheaded, etc.
How do you handle somebody that's on oxygen and heart disease at the same time? I bet you have lung doctors that say it's your heart. You have heart doctors that say it's your lungs. I'm just wondering how that affects the picture as a whole when it comes to heart health.
And I think that's the complexity of medicine, because the heart and lungs are intimately associated, and we often don't know what percentage of your symptoms or your problems are related to your heart and what percent are related to your lungs. People that come to us and have heart disease and lung disease, those are extremely complex problems. And our patients will come to me with severe aortic valve disease and severe lung disease, and they want to know how much better they're going to be after their valve replacement. And I tell them, I really don't know. Your valve needs to be replaced. There's indications that suggest your valve needs to be replaced or your coronaries need to be bypassed. But the fact is, I don't know how much better you're going to be until after we do it. And quite frankly, I don't know until 3 or 6 months after we do it. And so much of that depends on how hard you work after your surgery. So these are really complex issues. And
I was kind of wondering how it pertained to the treatment that Sharon's under. I meant, do you have people on oxygen that have that treatment for?
Who have
what do you call it
ECP,
again?
the ECP?
Yeah, ECP.
Would you be able to be on oxygen and use ECP, Regis?
I think it's possible. There's some contraindications for ACP, and being on oxygen is not one of them that I'm aware of.
We're going to take a couple more, and then we're going to let Sheila and Dr. Wickman have their turn as well.
I have one more question, please. With the high cholesterol, if a person has high cholesterol and the good cholesterol is at 90+%, and you have a higher cholesterol with your bad cholesterol, would you please explain to me where does that fall, or how does that play into a factor of being concerned as a woman to, heart disease?
That's a great question.
Sue, I have the same question.
Sue manages my cholesterol. I run our cholesterol clinic. So the HDL is a protective. A lot of people think of the good and the bad cholesterol. HDL is the good cholesterol. And in general, the higher the better. Okay, now I need to qualify that a little bit, because we've learned a lot about HDL over the last few years, and not all really high HDL levels are protective, because we know that some kinds of HDL don't work as well to remove plaque as other kinds. Now, someone that has an HDL of 140, for example, we come across that once in a while. There's not a good way to test that to determine if it's protective, if those are functional HDLs. But a lot of times we assume that they're not. So with that caveat, and I just want to throw that in, most of the time higher is better with HDL. But, and I can remember, I'm kind of old, and I can remember the days when we would say, especially if a woman has an HDL greater than 80 or 65 even, she can't have heart disease. And we used to say that to people. That was a number of years ago, and it's absolutely not true. So HDL is protective, but does it negate the bad fat? Not at all. You still want to look at your LDL. You still want to treat it if it's very high, and you're at high risk. So you still need to look at both of them, and that's why we at one point looked at ratios and talked about that.
Is it an inheritance factor?
Oh, absolutely.
That plays a great,
absolutely. Absolutely.
role
A lot
in
of
this?
it is. A lot of it is. In terms of HDL, a lot of it is inheritance, but you can do things about it. Mostly, we had medications that we thought that did help the number. But we're learning now that it really maybe didn't decrease the incidence of heart disease with the medication. So the best way to increase your HDL is what you can do, and that's weight loss and exercise.
Okay.
That's definitely the best way to do it.
Thank you.
A more practical question here is what to do, I think we want to know. So if you have high HDL, you are protective, no doubt. But if you have high LDL along with it, that high LDL will catch up with you. As you get older, especially when you go into the postmenopause years and moving on, you can develop plaque even with high HDL cholesterol. So if you have high LDL, it should be treated, just like if your HDL was not high.
That is a change in the way we used to think about it. There used to be a thought that as long as your HDL is high, we don't need to treat the LDL, and that is not true.
I'm going to share a little tip that I use myself because I can never remember LDL, HDL, blah, I couldn't remember. L is for lousy. That's how I remember. So that's my tip.
Low, you want it low.
Low, there we go.
HDL is for high, you want it high.
Oh, hey, I like that. That's one for each. See, I told you they were experts. Okay, we're going to take one more for this group, and then we're going to move on to our next story.
Why did the running not help? The exercise?
Yes, would you like to answer that? Why did my running?
That's a good question. I think what really helped Sharon here was the ECP. And we don't know how that works exactly. ECP, what it does is it pumps blood back into the heart during diastole, which is in between the heartbeats. And she mentioned a little bit about increasing nitric oxide, which is a vasodilator, is a chemical that dilates the blood vessels. But there are other ways the ECP may help also besides just developing collaterals. It may improve the circulation, the microcirculation or the blood flow at the microscopic level in the heart. It may decrease the amount of stress that the heart has to pump, the pressure that the heart has to pump to. So there are other ways that ECP helps that is very different than exercise. And I think that may explain why exercise didn't help in her case.
Right, but again, I guess I would like to point out again, and I know you've probably thought about this, is that I think it did help. You know, you're asking maybe why it didn't help prevent it in the first place. She was a lot older than her father was when he had problems. So
we need to put this particular story in perspective. Sharon has a very specific type of risk factor that create a genetic risk factor that created the promoted coronary disease at a very early age. Her father had his first bypass surgery at 41 and his second at 51. And you know, Sue is absolutely right. I mean, her lifestyle protected her for 15 or 20 years. I mean, had she been a smoker, she wouldn't be telling you this story today. I guarantee it. She would not be here to tell you the story today. Zero chance. And so it did protect her. But everybody here needs to understand that this particular risk factor, this genetic risk factor, is unique and not what most of the people are going to be facing. So
I'm just corrected. And so I thought you were asking why the exercise didn't help with the chest pain after the event. But I think if you're talking about why it didn't help to prevent problems, that's not very difficult to explain. Exercise is one of the best ways to prevent heart disease, but it doesn't work for everyone. When you have lipoprotein A levels, which is what she has, which is a rare type of cholesterol particle that plugs the arteries, lipoprotein does not respond to exercise. It's one of the few things that don't respond to exercise, which is lipoprotein. Actually, doesn't even respond to medications. So the only way we can treat elevated lipoprotein A is by lower that LDL cholesterol as low as we can. So it's just lipoprotein A is one of those things that are very resistant to treatment. And with her family history and having elevated lipoprotein A, exercise was very helpful. But like Bob said, if she had other risk factors and didn't exercise, she probably would have much more severe coronary disease. So it helped her, but it was not enough to prevent her to eventually developing symptoms and plaque.
So what's unusual about Sharon's story is her lipoprotein A familial problem. What's very typical about Sharon's story is her presentation and the way she managed it. So that's what's very, very typical about women's heart disease.
Did that answer your question?
Oh.
Okay.
All right, so we have another video to share of Sheila, and then after that plays, we're going to let Sheila talk about her story in her words, and Dr. Wickman speak as well. So let's look at Sheila's story.
I was 32 years old at the time, and I had been giving a presentation that morning, and I had, it was kind of an all-day event, and while giving the presentation, I started feeling really hot, and I was like sick to my stomach, almost where I had to stop and leave, but I wanted to continue on and get through it, and as fast as I could. And I just remember looking at the clock going, okay, if you can just hang on for just a couple more minutes longer, you'll be fine, and get to your car and go back to work, it'll be fine. We were just kind of sitting there, and I hadn't eaten anything all day, and I still didn't feel well. And we went to bed, and I got up, and I couldn't sleep all night. I was pacing back and forth, and I still felt sweaty, and it's almost like the feeling that your body is, your foot falls asleep. My whole body felt like that, and it wasn't just in one area, it was all over. And I'm like, oh, I had a pain in my chest, and it just kept on getting worse and worse. And so I woke Kurt up, and I just said, we gotta go, something's going on here. And right before that, I called my sister, and she's a nurse, and she just said, you're having a heart attack. These are all the signs and symptoms, but she's a new nurse, so I'm like, okay. That's the last thing I think most women think of, and I just put it off. I put it off because I didn't think anything was wrong.
When I tell Sheila's story, I tell people that this is one of the sickest patients I've ever taken care of who survived. You know, the basic premise was that she was not getting blood flow, and we had to do a bypass operation in order to restore blood flow to that portion of her heart. This situation is very unusual. You're right, the vast majority of our patients requiring bypass surgery are several decades older than Sheila was. But that first night, that night of her operation, she was so critically ill that I truly didn't believe she'd survive.
He didn't outright say it. He said that I have a very sick girl. He said it's serious and she's very sick. I'm pretty good at reading body language and reading what was in his eyes, and he didn't have to say it. I knew what he was saying.
He came in, and it was clearly his day off. He had jeans and a white t-shirt on, and he had a sucker in his mouth, and I was like, oh great, who's this guy? And he goes, I'm Dr. Wickerman, and you're gonna get your butt out of bed today. And I'm like, I don't think so. And he's like, no, I think so. And then I'm like, oh, I'm nicknaming him Cowboy. He was just a wild man. I'm like, you are just out of control. I'm not gonna get out of bed. He goes, you will walk today. And I don't care if it's just 5 feet, you're gonna walk today.
She was amazing. I mean, she was so strong and so amazing, and 8 days after the operation actually went home. Sheila's actually become a friend of mine, and so I have seen her. Most recently ran into her in the grocery store, and every time I see Sheila, it just brings a smile to my face, and it brings a smile to my heart, because she's just such an amazing person. Sheila and her husband Kurt are wonderful people. They're good friends of mine, and they just have such a positive impact on our community and me. So it's fantastic.
He's like family.
We bump into him every now and then in the store or something, and it's always a handshake and a hug, and asking how we're doing, and it's you can definitely tell there's something there. And there's a special connection, because this isn't something that we expected ever in our lives that would happen.
You hear about all these stories, and you see them coming through, and you interview all these different people, and you never believe that maybe this guy can one day save my life. I mean, I wasn't thinking that day, but just a big thank you to Dr. Wickman and his staff of nurses and everybody else who was there. They were wonderful, and I don't think you can find a better doc than Doc Wickman. he was amazing. You know, it's just like, boy, he's just a little, spitfire, and but he saved my life, and I'm forever grateful for that. So.
Sheila, Kurt, it's really an honor to be a part of this presentation. Thank you for everything you do. Thank you for the people you are. I love you.
Sheila, we're going to let you take a turn.
Well, I think like.
And I'm going to interrupt everybody and just remind you presenters, make sure that microphone's really close to your mouth.
Like Susan, I felt the same way. I didn't think anything was wrong. And honestly, at 32, I was like, hey, it's probably just gas, or maybe I was just really excited that day, or maybe I had too much coffee or something. And I don't think anybody realizes until you're like, okay, something's really wrong. And it's best to like really listen to your body as a woman, even as a man as well. But I think with my symptoms, they were atypical. They weren't what you read, and they weren't what you hear about happening. And for me, I was sweating all over, and I was like, something's wrong, but I passed it off like Susan did too. I didn't think twice. I was like, this can't be a heart attack. This is just nothing. And I think we go about our day-to-day lives, and we're so busy and caught up in that we don't realize, the bigger picture, like, wow, I could be having a massive heart attack. And I was having a massive heart attack, and I didn't even know. And until the next day when I went in, and, I think it rocks your world when that happens to you. And even at a young age, I don't think that there's any age put on a heart attack. You could have a heart attack at 20. You could have a heart attack at 16, 60, 80. It doesn't matter. And I think the most important thing to take away from it is listen to your body, listen to how you're feeling, and really take note that, wow, if something's wrong, I'm not going to drive to the hospital. I'm going to call 911. And really, try to feel like, okay, my life is more important than going to work or getting the kids dressed. I mean, you have to put yourself first. Your health is all you have. You want to be with your loved ones and see them grow up and all of that, but you really have to pay attention to your body too, and really take note of how timely things are, and really get help if you need it. And that for me, I don't think it matters at any age, but for me, it was all the atypical symptoms. So I was just sweaty all over. I had a stomach ache. I just felt like I was going to throw up. I had tingling sensation all over my body. It wasn't a radiating pain down one arm or anything. So for me, it was different than most women. So, and I think when doctors looked at me, they were like, she's fine. She's fine. There was no heart health history in my family either. I was healthy, so I didn't understand. But boy, I'm so grateful to be here and to share my story with you in hopes that, if something happens down the road where you're like, ooh, I wonder what that is, go get it checked out. Don't wait. I think, your life is precious, so you have to pay attention to your insides too.
It's a great message. Dr. Wickman, what do you want to say about Sheila? And then we also have a bypass slide for you.
Sheila, like Sharon's story, is not the typical story of coronary artery disease that we recognize on a weekly basis. Nonetheless, it points out very important concerns about heart disease in general, and the presentation of heart disease, and specifically the presentation of heart disease in women. And that is, it can be atypical, and you do need to have this sense of urgency about your symptoms. I think about why other types of health issues in this country get so much more attention than heart health. And if you think about breast cancer, for example, it gets so much attention. I mean, the evening news last night about this new study that comes out about mammography, and it creates an uproar about health care in this country, and it should. why doesn't heart health or heart disease get that kind of attention? And if I think about that, it's because you can't do anything about breast cancer. You maybe a little, but I mean, being overweight and smoking, and they have some factor in that. But for the most part, cancer is something that we can't control, but we can control heart disease. And I think to some extent we don't want to think about that. We don't want to take that on. So I guess my message is, we can affect our heart health, and we really need to listen and be acutely aware of, as Sheila said, we need to listen to our body, and if things aren't right, we need to acknowledge that and get the appropriate help.
So I have this slide that talks a little bit about bypass surgery. Do you think you could narrate the animation for us, Dr. Wickman?
I'll see it once.
It'll look familiar. And it keeps looping, so it'll just come back around.
So bypass surgery is, it's an invasive procedure. So unlike the things you've heard about tonight, bypass surgery is clearly invasive. And for the most part, 95% of the bypass surgery we do is through a sternotomy, so we divide your breastbone. And so it seems really invasive to people. Now, the vast majority of these we do with a beating heart. So here at Mayo and Eau Claire, we don't put you on the heart-lung machine and we don't stop your heart, but nonetheless, we divide your breastbone and open your chest, and that seems very invasive to people. So what we do is we bypass a blockage in your coronary artery with an artery or a vein. And the arteries are typically mammary arteries. They are arteries that are run on the inside of our chest, and we take those arteries down and we use those, or we take vein from your leg. Occasionally, we'll take an artery from your arm to do a bypass. So we take a piece of blood vessel that's in your body, and we use that blood vessel then to bypass a blockage in your coronary artery. People have this sense that we cut the blockage out. We don't. We don't cut the blockage out and splice in a new piece like maybe your plumber or your electrician does with a blockage in your house. We actually take an artery or a vein and we bypass around the blockage to a less diseased area of artery. Now, in Sheila's case, she had very discrete areas of blockage, which is not typical in the average patient that we see in our operating room. In our operating room, our 60, 70, 80, 90-year-old patients have multiple blockages throughout their vessels, and so we're bypassing the major blockages. And if you want to think about this, think about a tree. So the main branch, we can bypass the main 1 or 2 branches. And after that, it's disease that Sharon had. Sharon had small vessel disease. She had disease involving the small branches of the tree that have the leaves. And those we can't bypass. We simply don't have the technical ability. The vessels, for example, in Sheila's case, the vessels that we're bypassing when we do coronary bypass surgery are on average 1.8 millimeters. So about a 15th or a 20th of an inch. So we're taking your artery and your vein, and we're bypassing a blockage to an artery that's about a 20th of an inch. And so that takes, fantastic technical capability. But the smaller vessels, as in Sharon's case, we can't bypass those. And so we rely on other methods. In this animation, what you see is a blockage, which is in that red artery, and you see a vein bypass around the blockage. And so we've taken a piece of vein out of the leg, and we've sewn it from the aorta to the artery beyond the blockage. The red artery to the right is the mammary artery, which is that artery running on the inside of your chest. And we've taken that down, and we've sewn it to the artery. So here, what you see is the blockage that's been created. You see a piece of vein in blue taken out of the leg, and then we sew that vein from the aorta to the artery beyond the blockage. And on the right-hand side is that artery that's been sewn beyond the blockage to a different coronary artery. So some patients are candidates for bypass surgery, typically patients with multiple vessel disease, diabetics, patients with with decreased heart function. And then some people are candidates for stents, and some people are candidates for other therapies, as Sharon's had. So those are the sort of the main statements about coronary bypass surgery. And it's really up to then your physicians to decide who's a candidate for bypass surgery, who's a candidate for stenting, and who's a candidate for these other modalities that are less common. So.
In the last slide, Dr. Wickerman, you talked about working hard, that after surgery, if somebody has other concerns, it's part of what they're putting in, and that's a picture of rehab.
Yeah, I think rehab is probably one of the most understated components of what we do. And people always say, oh, I'm really concerned about my husband, or I'm really concerned about my wife, because they're not going to listen to you, and they're going to want to get up 3 days after surgery, and they're going to want to go home and do something. And I'm like, great. I never worry about those patients. The patients who don't do well are patients who don't go through rehab, or patients that don't want to get better. We can provide you an operation which, quite frankly, makes you probably worse than you were when you came to us, because it's a trauma. I mean, surgery's traumatic. What we rely on is the healing process, and then we rely on that patient to go through rehab with these experts who know how to help you through it. And we rely on your enthusiasm to get better. And the people on stage today, Sharon and Sheila, had phenomenal enthusiasm to get better. And that's why they're here telling you their story today. So we can help them for a short period of time, but then we really rely on their will and their enthusiasm for life and to get better. And I can't tell you how these two women just exude that enthusiasm for life, and it's fantastic.
We're going to invite some more questions. I'd ask you to raise your hand again. Jeannie will come around with the microphone. Please put it right up to your mouth.
Yeah, Sheila, I have one more. During the ECP, did you do any rehab then, or was it after, or how did you feel if you had it in the morning? How did you feel in the afternoon for doing anything, for exercise or?
You're asking?
Yeah.
Oh.
Mm-hmm.
I really enjoy rehab. I still do it. I do the phase 3 rehab, and I've met so many good friends, people that I talk to. We can talk about things, crazy things that other people, they just don't seem to understand, to have that camaraderie and to be able to exercise. The time goes so quickly, and we do so much. It just offers so much than I think anyone can realize.
But Sheila, did you do how did you feel after you had a session of ECP? Like if you had it in the morning, did you feel like doing anything in the afternoon, or were you wore out?
The first, I would say the first couple weeks, maybe even by the third week, I was really, really tired. But around I'd say, third, fourth week, you get this energy, and then you start, it's amazing. Even my husband noticed that. He says, wow, you have so much energy. But it wasn't right at the beginning. It takes a few weeks, and then, yes, you definitely have more energy.
Thank you very much.
Mm-hmm. You're welcome.
Any more hands out there? We got some down way in the front, Jeannie.
I was just wondering, how is the advancement for your microscopic surgeries come in as far as heart surgeries? You hear this about the technology for microscopic stuff being done as far as surgeries versus the invasives of cutting your chest open. How is that advancing?
I think the advances in the treatment of coronary artery disease are several. Number one, the stents that the cardiologists are placing today are better than ever. And every generation of stents, which is probably about every 2 years, they're just better and better and better. And so, quite frankly, the volume of coronary bypass surgery in this country has dropped fairly dramatically in the last 5 years or 10 years because stenting is so good. Two, we do here at Mayo, we do the majority of our coronary bypass surgery without the heart-lung machine. And that's been now, we know that that's a huge benefit to our patients. the neurologic outcomes, the cost, the time in the hospital, the recovery time is better. So that's a big advancement. As far as the microscopic treatment or the actual technical sewing of the vessels, there hasn't been significant changes in the past several years. The use of more arteries for bypass as opposed to veins is extremely beneficial. So there have been tremendous advances in the treatment of coronary artery disease over the past 10 years, even here.
There's a couple right behind there, Jeannie.
Dr. Wickman, you corrected mom had a ascending aortic aneurysm, and it measured over 8-point-some centimeters, and she just has this question: how large of an aneurysm have you corrected? Where does that stand in the? And then I have the question, because she's had this, and now she has a newly diagnosed descending aortic aneurysm. How does that affect me in incidence?
Well, it's appropriate that during this Olympic week or this Olympic 2 weeks, I think that we should give her the gold medal, because that's a big aneurysm. I mean, we have OR staff here. We don't see aneurysms over 8.5 centimeters. I mean, that's huge. So that's as big as we see them before they rupture, and people,
and therefore, we want to give you the Olympic medal.
Yeah, that's nice.
So that's kind.
I was told I would have to go to Rochester to have it done if I chose to do it at all. And Wendy called you and at Mayo, and they said, bring her here, we'll take care of her. And you did.
Nice.
It's great to see you. That's an enormous aneurysm. The risk of aneurysms is that they rupture. So an aneurysm is an enlargement of an artery, which in the definition of an aneurysm is an artery that's 2 times over the normal dimension or diameter. And the problem with aneurysms is they rupture. And 95% of patients who have a ruptured aneurysm don't survive. So, and the problem with aneurysms is that they're very difficult to diagnose, because the vast majority of patients don't have symptoms. So whether it's in your chest or your abdomen or behind your knee, the vast majority of patients who have aneurysms don't have symptoms. And so screening or, understanding the risk factors is extremely important. And the risk factors of aneurysms are age, male sex, smoking, family history. And so family history is a risk factor. So it's clearly something that you want to think about, and you want to, let your doctor know about. It's an important factor in the occurrence of aneurysms.
So that's a practical, question. So you want to know how that affects you, and aneurysms of the ascending aorta, which is the initial portion of the aorta, are very likely to be genetically triggered. So if a person has a bicuspid aortic valve, which is an abnormal valve in the aorta, and an aortic aneurysm, all first-degree relatives should be screened. So there are certain conditions in medicine that there are specific recommendations to screen all the first-degree relatives, and this would be one of them. So you don't have to remember that. You just have to remember that when you see your doctor, if you have a family member, first-degree relative, or your mom that had an ascending aortic aneurysm, you should just mention, and they should be able to look into it to see if you need to be screened. Screening is easy. You'll build an echocardiogram to see if you have the same problem.
Any other hands?
This is for either of the MDs. If you have to insert a stent into a patient because of the existing conditions, is that patient then therefore on medications for the rest of their life?
Yes. So there are a few medications that are important regarding placement of a stent. One of them is a blood thinner that has to be taken for a period of time of approximately a year. That can be stopped. But the key is prevention. So one of the important messages that we want to all you to take home here is on the prevention side. That's why me and Sue are here to talk about that. So if you have a stent because you have a blocked artery because cholesterol build up in there, you have to take medications to try to prevent other arteries to end up the same way that the one did that you had the stent on. And lifestyle modifications, exercise, weight loss, this is all very important. But studies have shown that once you already develop the disease and you end up getting so bad to the point that you needed a stent or bypass surgery, medications are by far the most powerful way to prevent you from having that again. So it has to be added to the lifestyle changes that you make. So unfortunately, you have to take medications for a lifetime. Another medication that is important is aspirin. Aspirin has been shown over decades to be one of the most important ways to prevent heart disease after stenting or after bypass surgery. And that's something that we strongly recommend people to keep taking for the rest of their lives.
Is there any other hands? We're winding down here.
I have a two-part question. First, any advantages from taking a vein from your leg versus your chest? And secondly, if you've had the veins stripped in your legs, what impact does that have?
So really the distinction is whether you use an artery or a vein for bypass. And arteries are so blood travels out of your heart through arteries, and it travels back to your heart through veins. So arteries are high pressure systems, and veins are low pressure systems. And so we often take veins from the leg to do bypasses, and they're not used to seeing high pressures. And we now know that at 10 years after bypass surgery, if you take a large series of patients who've had bypass surgery, after 10 years, the mammary artery, or the artery from the chest, about 90% of those are open at 10 years. If you look at all the veins we use from the legs, about 50% of those are open. In fact, some studies would suggest that it may be even less than that. That 35 to 50% of all veins are open at 10 years. Now, part of that depends on how you modify your risk factors. We know that modification of risk factors after coronary bypass surgery is extremely important. So if you think that modifying your risk factor before coronary bypass surgery is important, modifying your risk factor after coronary bypass surgery is doubly or triply important. So that's also a factor. But our arterial bypasses tend to stay open longer and tend to be better grafts than vein bypasses. Now, the problem with that is there's only so many arteries we can take. You have 2 arteries in your chest, and we don't like to take both of those in diabetics because we know that if we take both the left and the right mammary artery in diabetics, they have a much higher risk of wound infection, and over 50% of our patients are diabetics, so it really limits how many mammary arteries we can take. And then we like to use the radial arteries, or the arteries from the arms. We like to use only the non-dominant arm, and we tend to use those in our younger patients. So there's only so many arteries that are available, and the rest then have to come from the vein. Now, patients that have had vein stripping, that's sort of a heart surgeon's nightmare. And but nonetheless, we then find other bypass. We find other places to take conduit or to take pipe. We'll use both mammary arteries, we'll use the arteries from the arm, and we will use other vein from the leg. There's a vein that runs behind the leg called the lesser saphenous that we'll use. So it's a problem, but not something we can't fix, we can't manage.
The internal mammary artery is extremely resistant to atherosclerosis. I have yet to see atherosclerosis or narrowing of the conduit of the mammary artery. We see progression in the veins, we see progression in the native arteries that you're born with, but that artery, that internal mammary artery that Bob uses from the chest, is extremely resistant to atherosclerosis, regardless of what kind of risk factors you have. So it's just something to remember. So it's a very important part of surgery. And Bob always makes an effort for every patient to have an internal membrane whenever it's possible when they need bypass surgery, because we know it's going to last a lifetime.
I'm going to invite one more question. I know there's probably more, but I'm sure our presenters will be around for a little bit, so you could grab them afterward. Let's have one more question, and then we'll wrap it up here. Oh, they won the lottery back there.
Mine is
here as long as.
Oh, and they'll stay here as long as you want.
Mine is
Look
very
at that.
quick. You mentioned an aspirin for the rest of your life. You talking baby aspirin or full aspirin?
Okay, so that's a very good. I get that from my patients all the time. In the laboratory, the platelets, which are the little cells that we like to inhibit by giving aspirin, are inhibited with doses less than 50 milligrams of aspirin is enough to completely inhibit the lifetime of the platelet, which usually lasts about a week. So 50 milligrams would be enough. Now we use 80 because that's how it becomes available. So nowadays, that's the dose that we're using for most people. 325 has a slightly increased risk of bleeding complications in the stomach, etc. So there's no study right now saying that there's an advantage of taking 160, 325. And so 80 milligrams is the standard that we're using right now.
And
so
80 is the baby?
Baby aspirin.
Regis, what percent of patients are aspirin resistant? I mean, we now know that there's a certain segment of patients that are resistant to...
Yeah, that's a problem. There are a lot of patients that are resistant to aspirin. And a lot of patients are also resistant to Plavix, which is the blood thinner we use after stenting. So we have new drugs similar to this Plavix that overcome that resistance, but we have a lot of patients that are resistant to aspirin, and we don't have a way to actually measure that or to detect that.
You want to keep going, you guys? Two more? Okay, two more. Spread them around, Jeannie.
Right here in the front.
Somebody down here, yeah.
Well, I'm going to speak for my husband here. It was quite a shock. He was having this cough, so the symptom for him was totally different than what I've heard tonight. He said he just had a cold, and I said, after 6 weeks of coughing, I said, this is ridiculous. So I said, you're going into the doctor, and we went in. And lo and behold, the doctor looked at him, checked his chest, and said, I got to do an EKG on you. We both looked at each other and thought, we were going in for some cough medicine, So anyway, they did the EKG, and she came in, and she says, I want you to get in the hospital right now. He had AFib and congestive heart failure. And he was in the hospital 6 days, and they tried to shock it to get the AFib back in line. Didn't stay. So now he's on warfarin and a whole bunch of other medication and that. 35, I think it was part of the bottom of his heart was not working right. I don't understand any of the technology, but anyway, this warfarin and keeping it, he's going in all the time, for the blood checks, and sometimes he can go a month because it's good, and then it's got to be every week. It's very upsetting, and how can a person regulate that more, or what can a person do? It stresses me out, so I'm in the line of being stressed out.
Well, I think this points out several things. Number one, again, a pretty atypical symptom for heart disease, cough. And yet what you were having was some degree of heart failure that was affecting your breathing and with fluid in your lungs, and that, for you, that was a cough. And so it really points out what the main message tonight is, and that is you can't have enough sensitivity to your symptoms and to your body to get help when you need help. And this is another great example. As far as managing your atrial fibrillation with Coumadin, it's a hassle. But not taking blood thinner with atrial fibrillation, the risk is stroke, and so that's something I think we all fear significantly. There are other medications that are being used for atrial fibrillation today that Sue and Dr. Fernandez can talk about, but the main drug still in this country is Coumadin for the treatment of, for the thinning the blood for atrial fibrillation. So.
Strokes from atrial fibrillation are devastating. They're usually very large and very debilitating. So we always have to remember, whenever we are concerned about the warfarin, the Coumadin, the rat poisoning as they call it, we have also to remember the other side. What if I don't take what can happen? And a stroke is irreversible and is there forever. Now, like Bob said, there are new drugs. Now they're coming out the pipeline for atrial fibrillation that do not have a lot of the disadvantages that Coumadin has. They cost more, but eventually they'll become more affordable. And I think in the future, I can see in the future Coumadin going away and only these drugs being used for atrial fibrillation in the future. So just hanging in there. And
it just was a shock to me because the year before I'm out jogging on the cancer race, running 2.5 miles out of 3, got 4th place, and all of a sudden, a few months later, I'm just a little bit short of breath. So that's kind of a hint for everybody around here. If you have a shortage, not, being middle age here, might have had a factor in it, but I felt myself healthy and, excited to be able to do everything I could do. And then all of a sudden I'm a little short of breath and coughing, and so that was a stressful part and a shock to me.
And that's a really important point because we do attribute that to aging sometimes. We say, oh, we're more short of breath or we're more tired because we're older, and that plays into it a little bit, but not much. You certainly want to look into and come and see us and see if there's something else going on.
Yeah, just think about the statistics. The leading cause of death and hospitalizations and cost in healthcare is heart disease in both genders, men and women. So when you start having symptoms of something, if you cannot explain, if it doesn't seem the typical cold or the typical, what is going on with me, there's a good chance that it could be heart disease.
I'd like to personally thank Sheila and Sharon for their bravery and be able to sit up here and tell these very personal and difficult stories. And I'm grateful. Thank you.
Sharon and Sheila, anything you want to add, ladies?
Just follow your instincts. If it feels like something's going on, get it checked out. If you're, the old adage, if your mother says she loves you, check it out. But I'm very grateful to be here, and all the doctors and nurses that worked on my case, and for my family. I couldn't, it couldn't have turned out better. It could have turned out much worse. So, thank you.
I agree entirely with everything you say, and I just want to remind you all to please take care of your heart.
I just wanted to thank these ladies and let you know that those flowers next to you are for each of you. And we're just going to leave this up for you. These are 5 tips. I hope you come away with things that you can do to protect your heart, just like they have done and are continuing to do. The best part, of course, of anything is presence. So we've given ourselves the gift of heart health tonight, the gift of time to learn some good medical information. I do have a couple extra presents that I drew some names for. So I just want to read these off, and then after we're finished, you can come up and collect your gift if I've read your name. If you're not here, if somebody's left, I'll mail it to them. So we're going to start. The first 2 are these books, which is a Mayo Clinic Healthy Heart for Life book. Dr. Fernandez is actually a contributor to that, so maybe he'd sign it for you. I don't know if it's worth any more if you do that, but he'd do that. So I've picked that for, if I say these right, Delbert Friedel and Melissa Durbin. All right. So those are for you. And then we have a couple of these bags, so I'm going to read 5 names. We have, they got to be red, right? Red lunch bags, and there's a little something extra inside. And that's for Kathy Forer, Trudy Grill, Virginia Erickson, and Lisa Bulkholtz, and Pat Hebert. I hope I said those right. Thank you all so much for coming. Make sure you've got your flower, your water bottle, and happy Valentine's Day Eve.